A very good afternoon to all the audience and all the respected seniors, dignitaries, my colleagues from surgical department, cardiology, and good to see a huge crowd is gathered over here. So I'm very happy to be here. And special thanks to the organizers, Aisha Mullah ma'am, Mihir and Falak, and the entire physiotherapy department to consider me to talk and discuss out the things with you. So let's directly jump to the topic. My topic is from OR, the operating room to home. Bridging the gap with the cardiac rehab. Much a talk about and much a known topic, but not much practically practiced topic. I am Dr. Pratik Manik. I am an associate professor in Department of Cardiothoracic Surgery. So, why do we say from OR to home? Why don't we say that the patient is just operated is good? So, whenever we see a patient in the outpatient department, I would like to discuss rather than discussing the slides out. You can read the slides parallel. So see, whenever we see a patient in the OPD, the patient never comes that कि सर ये वाल का ऑपरेशन है, वाल बदल दो या वाल का ऑपरेशन है, ठीक कर दो. Patient comes with a complaint that he is doing something, he wants to do something and he is having some limitations in doing that. It's we who tell them that there is some valvular problem or there is some coronary problem or there is a failure therapy or there is some problem with the heart. He doesn't know that. What he wants is वो जो activity कर रहा है, whatever activity he is doing, that is being limited. And what he wants from us that he goes back home and does the same activity without any symptoms. He's coming to the hospital to just come here and go back and do the same thing what he was doing. He's loving his routine. He's loving his life. He wants that same thing to be there. He doesn't want that you do the surgery and then after the surgery he's stuck to the bed and he's just watching a TV. I know many of them do like that post-operatively. We would see the reality also. But the fact of the matter is everyone. And that is... See, the cardiac part is much more ignored because even not much from the physician or surgeon side, we are much involved in the rehab. Moreover, there is some fear that a cardiac surgery has been done. The rehab is not that possible, or the rehab can take a back step. Saving life is more important than you getting back to life. Same thing अगर आप ऑर्थो में सोच के देखो, if a patient is getting operated and he is not able to move around, the patient will kill you. He will डायरेक्टली वो तुम्हें लीगल केस कर देगा कि तुमने तो बोला था चल के दिखाएंगे, चल तो पा नहीं रहे. सो दिस सेम थिंग शुड डेवलप इन द कार्डियक रिहैब ऑल्सो. Patient has to be aware, the physician has to be aware, the surgeon has to be aware, and simultaneously you guys are aware, but then more and more involvement and more participation is required, both from patient as well as from the rehab side. So yes, we are aware the cardiovascular disease, the rise, there is a lifestyle disorder, more and more comorbidities, so you mean more and more cardiovascular diseases. Younger patients with more comorbidities, younger patients with cardiovascular disease, more of the life years they are going to spend with this disease. So more of the life years means more of the life years they are not going to sit in the bed. For example, if you diagnose a patient with a heart problem, he will stay on the bed for one month, 2 months, 6 months, 1 year. After 1 year, he will get frustrated and tell you, sir, this is not what I wanted from you. This is not what I wanted from the surgery. I want to go back to my normal life. So that's where the role comes. You have to bridge the gap with the cardiac rehab. It's much a talk about thing, but reality is different. We are not able to give that to a patient still. So it has a major role, especially in long-term outcomes and ultimately the quality of life. The quality of life has to be at least the normal, at least back to normal. Not just he expects कि अभी जो चल रहा है उससे बेहतर हो. He wants to be better than what he is right now. Right now he is with a problem, but still he is doing something. He says that if you are curing me of a problem, I should be more better than what I am right now, post-surgery. So what do you mean by cardiac rehab? It is a complex interprofessional intervention. Interprofessional, why do we say? Because cardiac rehab comes after and before the part. But the center point is the patient is being treated for some disease. So every point of the contact of the patient in that disease process is a part of a cardiac rehab. And the rehab has to be customized to the individualized patient as well as to individualized disease pattern or the pathophysiology of the disease. उस हिसाब से you have to plan, be it ischemic heart disease or the patient is directly landed up into heart failure or the patient has undergone a surgery. For example, post-op surgery patient is there and patient is already having pain and you are on the first day saying, come on now, get up, sit on the chair, start walking. He cannot do it. So it has to be individualized as per the patient. He has pain, so you have to go slow. If you tell them you don't have to do these things, he will be very well aware. Then let him do the other things. He will confidently be able to do that. Or if the patient has undergone a stenting or a percutaneous intervention, like an angioplasty. So what is our aim of a rehab? So we want to limit the psychological and physiological stresses of cardiovascular disease. We want to improve it. We want to bring him out of that fear, the psychological barriers as well as the physiological barriers that is limiting his activities. At a long term, we want to reduce the mortality out of it. We want to improve the cardiovascular function as well as the entire bodily function so that the best possible quality of life can be achieved by him. What does it do? It also helps in halting the progression of the disease. Like sir said, that primary prevention karna hai, physician se milna hai, and after some age you start doing exercise, you start doing this and that. So the rehab not only brings you out of the disease, it also prevents and it also helps in progression of the disease. If the disease is going to progress by the same rate, then the patient will say, better I'm at home rather than coming to you, getting at the treatment at the hospital and then going back again with some problem. And this how it increases the patient's self-confidence, and he now gets back into his routine. He can play, he can do his job, he can do all the routines. So that is more important for us. So if you look at the components, so there are many components that you have to take care of the vitals, you have to take care of the patient physique, the weight, entire assessment of the patient, nutritional status of the patient, the blood pressure, the diabetes, how psychologically is motivated, how much is the family supporting the patient for the rehab, how much the physical activity is possible, and then how much exercise training is possible and how the exercise training is going to progress further. So any patients with a heart condition is a candidate for a cardiac rehab. But there are some of the conditions which we want to avoid. What are these? So if the patient is having unstable angina, what do you mean by unstable angina? If the patient is sitting at rest and is having angina, means a chest pain due to a coronary artery disease, you should not do it. If it has a decompensated cardiac failure, if the patient is not, if the medicines or the therapies or the lifestyle is not able to, achieve a compensated phase of the heart failure, in decompensated phase, you cannot do a rehab. He's having some of the other ventricular arrhythmias, he will be having problem, he may have giddiness while he's doing rehab. Severe PH, patient may start developing hypoxia with the patients who have severe PH. If there is any thrombus in the heart, or if there is any history of pulmonary embolism, or is a high risk of pulmonary embolism, some of the obstructive lesions like obstructive cardiomyopathy or obstructive valvular disease, when the blood is not flowing across the valve, then you cannot do a rehab. You cannot make the body demand more blood when the heart is not able to pump blood. Or there are some systemic factors of the musculoskeletal physiology such that you cannot put the patient to a rehab. So it's definitely a team approach. First of all, the patient is needed. The patient has to be motivated. The patient's involvement is definitely needed. The family has to support, because in-house or inpatient post-operative rehab will be taken care by the doctors, nurses, the staff. But at the home, the patient needs the support of the immediate family so that he is motivated, he is confident to do that. The surgeons and physicians' role, it is very important, because see, whenever we do a surgery, if my patient is getting operated today, for example, he is on ventilator for tonight. We are just assessing everything. Everything is fine. Everything is fine. No complication, no bleeding, anything. Next morning, if he is getting extubated, the patient is talking with me. I am going on around. And if I feel that my patient is not active, he is not very much, cooperative, he is not motivated, or he is feeling feared and all, then even if I go and do another surgery, I have a nagging thought in my mind that if the patient is not motivated in a day or two, or if he doesn't do the immediate rehab, he is going to land up into complications. We know that. So the moment with the next day that we feel that the patient is totally fine, vitally stable, there is no surgical problem is there, we immediately call our physiotherapist, चलो इसको chair पे बिठा दो, इसकी physiotherapy शुरू कर दो, इसको spirometry करवा दो, some or the other thing, just the hand movement or just the limb movement, something. The patient has to be motivated right from the day one. The moment you think that the patient is ready, start rehab. So surgeon and physician has to be involved, and we are usually involved. We are involved in directing others that please do the rehab. But we have a thought constantly in our mind that the rehab is an essential part. So the physiotherapist, the cardiac physiotherapist, the major role, and the nutrition part and the ancillary part is taken care by the dietitians and the nurses. They are a part of the team. They are not away from the team. So classically, there are 3 phases of any cardiac rehab. First phase would be the clinical phase. The second phase would be outpatient aggressive phase, and the third would be considered as a maintenance phase or the post-rehab phase. So the phase 1, a lot of things is written, but phase 1, just one thing, the patient is in the hospital, it is in-house. Once you are ready, once the surgery is done or once the therapy has been given, the patient has compensated, he is stable, he is ready for the rehab, you start rehab. So what do you have to do? See, the most important part, we have to assess the physical ability of the patient, whether he is still ready, whether he is ready to do the rehab. If the patient is already, having severe pain, some arrhythmia is going on, some hemodynamic derangements is going on, and if I tell the physiotherapist come and do a rehab, he will say that, are you crazy? We cannot put the patient to the risk. So we need to assess the patient, whether he's stable, he's physically able, at least he should be able to do that. He should be motivated. If he feels he's not able to do that, he should be motivated. Tolerance has to be developed. And what it starts with, non-strenuous exercises which are, on the bed or just bedside, sitting on the chair, moving the limbs, talking with others, doing physiotherapy, doing with spirometry, limb movement, all that. And then we gradually put him to activities of daily living. What do we mean by that? Once the patient is out of the ICU, there is a constant, upgradation of the rehab going on. Like chair sitting ho gaya, then you walk around the bed, then the patient walks in the ward. Then you ask him that you go to the washroom by your alone, do your brushing of the teeth you're alone, go and have a bath, come back. If you feel any problem, just tell us. Then the whole day the patient roams about. He is told that do this thing, do that thing. So what we want, that whenever he goes home, he's fully confident. At least the basic activities which he's supposed to do at home, the family should not fear that. The patient should not fear that. Right. So in this phase, it is important that before discharge, the familial discussion also happens. It's not like you just explain the patient that, see, these are the components of rehab, do this thing, do that thing. Now, he will go and do everything confidently at home, but then his relatives is worried. Yeah, he is doing this, he's doing spirometry, he's moving his limbs. I don't know, his heart will go weak. And the next week when the patient comes in the OPD, he's like, he doesn't listen, he does not sit down, he's constantly moving about. This is the 80% of patients relative complain that he's not sitting at one place. We don't want that. We don't want the patient to sit at one place. But see, the family has not been explained. The immediate relatives don't know what is the importance of rehab. They have not been counseled about that. And so they have to counsel, they have to be educated, and then the discharge has to be planned. So whenever we say that, especially the rehab part is more important discharge, what happens is that many a times the cardiac rehab physiotherapy is doing, but many a times the patient gets discharged, they don't know the patient is already discharged. So it's important, they are a part of the discharge policy. See, whenever you do a discharge, we do write the medications, the surgeon sees the wound, assesses the patient completely. Many a time the dietitian comes, explains all the dietary requirements. But we have to put that thing in routine, that the rehab person comes, the physiotherapist comes, he knows that the patient is getting discharged, what is to be explained before discharge. Well, half of the time he comes for the round, he doesn't know that the patient is already discharged. That happens here also, and that is practically that is not expected also, and even we don't want that thing to happen. I don't say that they are not involved. He came and he came to know that the patient is discharged. It's not that he didn't come, but he has to be informed. So that has to be involved. That has to be involved from our side also. We have to intimate them. The patient is discharged. Come and explain them what is to be done at home. So the next phase is the outpatient rehab. It's said up to 3 to 6 weeks. Maximally it can progress up to 12 weeks. So once in the outpatient department, the patient has been cleared by the surgeon or the physician that yes, now the outpatient rehab can continue. He is very well stable. Stitches are removed. Echo is fine. X-ray is good. He is up and about. Everything is fine. Medicines are controlled. Well optimized. So you start the outpatient rehab. So what happens is now we are focusing on the factors that are limiting his regular physical function. For example, he was driving a scooter before that, or he was driving a car. He was driving a bicycle, but now he is not able to do that. So now that phase comes when you want to put him to his previous activities. So this is a part of an aggressive phase. Your initial clinical part has been taken care of. He's the routine thing he's doing. Self-care is taken care of. Now he wants to roam about. He wants to go to the garden. He wants to talk with people. He wants to travel. So then that part has to be taken care over here. And any, again, comorbidities has to be taken care of, like the blood pressures are shooting up or some lung function is taking a problem in doing the rehab. Then you have to take care of that. So it is a more rigorous, a patient-centered therapy. And again, all the things come into play, like you have to inform them, you have to advise them, a tailored training program is devised for them. And then you have to give what time they have to relax, what time they have to do the rehab, all that. So coming to the third phase, so it's the post-rehab phase or the maintenance phase. It's getting more about, the patient then starts self-monitoring. Now, if you tell the patient that you in the second phase, you tell him now you start climbing the stairs. Okay, so he starts climbing the stairs. He does that confidently. Now, in third phase, he will come and say, you told me to start climbing the stairs. I'm doing that, but I don't know how many stairs I should climb. Should I go to first floor or second floor or third floor or fourth floor, or how much I should exercise? So now if the second phase is taken care of, the patient will be very well oriented. What limitations do I have and where I have to be self-aware of that. So now there comes the phase of a self-monitoring and becoming more independent from us. Now he gets into a self-rehab pattern. He climbs up to 2 stairs. He feels, no, today my 2 stairs are enough. So then he has to realize that now if I have to progress further, then I have to again, be more independent and more aggressive in whatever has been taught to me, like strengthening or the aerobic exercises or improving the flexibility of the muscles and the entire body. So again, nothing much required. You just have to encourage the patient. He will just come once in a week or once in 15 days or once in a month. You just have to give encouragement, ask him to maintain an active lifestyle, continue the exercise. And again, over here we have an online monitoring program also, where we can do a Zoom meeting and we can do a rehab. It's very well coordinated. So all this, if this phase is like maintaining and then continuing further. So now the complications of rehab, very important, because even the physiotherapist feel that a CABG has been done or a valve replacement is done. If I give him this exercise, if he lands up into some problem, I'll be in trouble. So it's never like that. Most of these patients are compensated well. The medications are optimized. They have been cured of a disease. They have not been given a disease. So if they are cured of a disease, they are definitely a better candidate for rehab than before. So literature says that the complications are very rare, like 1.3 per million hours of the exercise. And moreover, we have seen that the complications in the rehab arm in most of the trials has been lesser when they have compared with the control arm. So again, we look at the clinical benefits. So it increases the quality of life. It reduces the healthcare costs overall. So see, once the patient is independent to do a rehab and he is doing everything well, he will stop coming to you. He'll just come once in a 6 months or once in a 3 months. But if he is not confident, if the relatives are not confident that he has recovered, वो हर हफ्ते तुम्हारे पास आएंगे. And if his costs will increase, the healthcare cost will increase, the medication cost will increase, the overall cost will increase. Your engagement will also increase. Your time will be occupied more. So the more the aggressive the rehab, the better the quality of life, lesser is the cost, more physiological benefits, exercise training. It improves the mixed venous oxygen, the VO2 max, the endothelial function improves, the overall long-term outcomes improves, the myocardial reserve flow improves, and the better part, the cardiac rehab helps them to get rid of the old habits, like it brings down the smoking, it reduces the body weight, the blood pressure starts optimizing, the lipid control is better, the sugar controls are better. So one thing and lot of things can be achieved with that. And a psychological benefit also, because everyone knows the more you exercise, the more you get rid of the depression and self-confidence increases. So even in post-rehab or in post-surgical phase, there has been seen there is a reduced incidence of depression. Majority of the patients undergo the surgery, they have psychological barriers more rather than the physical barriers. So once the patient is aggressive, you have achieved the phase 2 very well, your patient will not have those psychological barriers. It reduces hospital admissions, and all-cause mortality improvement has been seen in the patient with heart failure also. So our goals, again, it reduces symptoms, improves capacity, and most important, the long-term outcomes, because it improves the long-term outcomes and reduces the progression of disease, as well as it reduces the risk of sudden death and any risk of reinfarction. But again, we know the reality is not true. Whatever said and done, everything is good, but in reality is not that good. Patient participation is very low in cardiac rehab. Nearly 30-35 literature wise also very high. I would say nearly 15-20% would be the participation rate by the patients, and especially in the secondary prevention programs after any intervention, because the psychological barriers are very high. And what are the reasons? Would be like a low referral rate from the surgeon itself. So if in the OPD the patient comes, surgeon is he just sees the blood pressure, the sugars, the medicines, everything is fine, the echo is fine, the X-ray is fine, the relative is counseled well, because half of the time it's important to counsel the relative rather than the patient. The patient is always not much in a worry rather than the relatives. So there are very low referral rates in Western countries, not in our institute, but in Western countries they have seen that the cost of the rehab is going up very high, and the companies or the insurance policies, they don't cover the rehab costs. Patient motivation is always less. That will be less, but that's on our part. We have to motivate them. And program site accessibility is still less, especially in our setup, where you don't have a setup like UNMICRC or the experts like Madam Aisha or the Mihir sir or Falak ma'am or the entire department that they take care of the rehab. So it's very important that patient do have the access also to such a rehab. So what are the patient barriers? So most of the studies have shown that the psychosocial barriers are more. Patients say we don't have time much for the rehab. 1 घंटा आना है, फिर आधा घंटा rehab करना है, फिर 1 घंटा travel करना है. It's not possible. There is a fear of exercise. Hardly I've got a bypass done. इतना risk वाला surgery था, I got out of it. Now I cannot risk more exercise and get more into trouble. And as we see, as sir told that most of our patients, they don't do exercise. Even if they're at the age of 40, 45, they are not active. Everyone is not a marathon runner and not even a treadmill runner. So he already has a fear of exercise. He doesn't have, susceptibility to exercise, or he's not exposed to exercise. So benefits usko pehle hi pata nahi hai. He doesn't know the benefits before, so he's not going to take the benefits afterwards also. If he's not aware before the surgery, he's not going to be aware after the surgery. So it's our role that as a team, we, take care of these points, and a proper program has to be conducted, proper accessibility to these programs has been provided. Well, thank you for this.